Hey everyone. That's my alarm to get on this call. I'm
Hey,
at
Bren,
the
can you hear me?
Yeah, I can hear you. Hi, Jacob.
Oh, that's great. I can't hear you. That's not good.
Oh, really? Oh, ooh. Okay, one sec. Okay, can you hear me now? Can you hear me?
Oh yeah, I can hear you.
Okay.
Yeah, I got you now. My audio wasn't up.
I was trying to do the headphones thing, but that didn't work out.
Yeah, mine are on the fritz right now too, and I can't quite figure it out.
Yeah, I don't know. I keep having audio issues with Zoom, but oh well. This is my first day back at the school, and it feels so weird.
Yeah.
Oh,
It's dead here, you guys. So strange.
what's everyone doing?
Good.
My hair is crazy.
Hi all. May I check to make sure my mic is working?
Yes.
Professor
we can
Watson.
hear you.
Yes.
I'm okay? Good.
There's the headphones working. Hey,
There we go.
so, Lami,
Yes.
I wanted to double check with you.
I
Mr.
just saw
Cannon
that
just
email.
failed.
Yeah.
Yeah.
So the first question was kind of general. Professor Watson, the question was about if there would be time for opening remarks in the beginning. And just in the interest of getting to student questions at the end, if you do have opening remarks, maybe include it in, in your first response. If not, we'll probably just add on the extra 30 seconds to that first question. But if you don't,
That's fine. And are you going in the order you gave us, or?
well, since you're arguing for Medicaid expansion, you'll go first. And we'll just get started when Mr. Cannon joins. Do one of you, actually, I'll do the timer. Sorry.
It says Cannon's on.
Oh, is he on? Sorry,
I just don't
didn't
see him. There he is. Oh. There he
Oh,
is.
Mr. Cannon, thanks for joining us. All right.
Thanks for having me.
Of course. So Brandon can get us started.
All right, awesome.
Ready.
Well, I will second that. Thank you all for coming. We're so excited for this Medicaid debate today. I just wanted to start off with a couple quick announcements. First,
Hey, Bren, before you do, because I don't have host status, I can't record. So if you could do that, that'd be...
we're already recording.
It is recording.
Oh, we are? Oh, awesome.
Yeah, Emily can send that to you after. Speakers, thank you so much for taking the time out of your day to help us law students learn a little bit more about this. We're so excited to hear from you guys. First announcement from HLA is that y'all just probably got an email from HIBA about shirt pickups for next week and tomorrow. So go ahead and take a look at that if you ordered a shirt. And then Jacob, any announcements?
Yes, because I am not contractually, but mostly just obligated to give it. I wanted to give the quick Federalist Society plug and also tell you guys our first event for next semester is going to be the 27th at 6 p.m. Of January. And that's going to be over Space Force. And right now we're trying to get our response person to be Senator, well, we think Senator Kelly from Arizona. But again, it totally depends if he answers his email. He's super busy right now. So I just wanted to say the Federalist Society for Law and Public Policy Studies is a group of conservative and libertarian law students, professors, and lawyers interested in the current state of the legal order. It's founded on the principles that the state exists to preserve freedom, that the separation of governmental powers is central to our Constitution, and that it is emphatically the province and duty of the judiciary to say what the law is, not what it should be. So in pursuance of an awareness of these principles, we're super happy to pair off with HLA today to give you this talk on something that's not just a national issue, but specifically an issue in Missouri as we're doing our Medicaid expansion. So with that, I think I'm passing the mic over to Lami to introduce the speakers.
Thank you, guys. Again, just echoing their sentiments. Thank you guys for joining us. We're really excited to go ahead and get into the topic today. So I will introduce Professor Watson. She is, of course, a SLU professor here. Lots of experience in Medicaid and health policy overall. Her experience really speaks for itself. And also we have Federalist Society was kind enough to bring in Mr. Michael Cannon from the Cato Institute. He's the director of health policy studies there. He's been featured in New York Times, USA Today, Washington Post, all the big ones. So we have really two juggernauts here to go ahead and discuss these issues. So because Professor Watson is arguing for Medicaid expansion, we'll start with her for the first question. The questions will have a 3.5-minute limit with a 1-minute rebuttal for each if necessary, which should leave us with about 8 minutes at the end for audience questions. So feel free to type your questions in the chat and we will bring them up at the end. So Professor Watson, getting into it, the first question, or I guess discussion point would, could you please discuss the benefits or applicable detriments of expanding Medicaid, specifically in the context of improving America's healthcare? Oh, you're muted, Professor Watson.
Once again, thank you, Lami, and thank you to the Federalist Society for having me today. Let me begin by putting Medicaid expansion in context. Medicaid is our joint federal state program where the federal government provides financial support for states to cover low-income residents to provide them with health insurance coverage. And now in Missouri, since we have not quite yet expanded, we voted in a ballot initiative to do that. I want to explain who's left out of Medicaid without an expansion. Here in Missouri, that means adults between 19 and 64 who do not have children that they're taking care of. That could be a 55-year-old person who's working as a landscaper, that could be a hairdresser, that could be somebody working as a barista. We do not provide any coverage whatsoever for low-income adults who aren't caring for children. And for low-income parents, their income has to be under about $4,500 a year for a family of 3. So we call that a Medicaid gap. It is simply unaffordable for those people to be able to go into the health insurance marketplace and pay the full cost for health insurance. Most of them are working, but most of them are not offered employer-sponsored health insurance. Medicaid expansion is really a way to fill in the gap for low-income wage workers so they can get health insurance coverage. And we're talking individuals with incomes up to about $18,000, a family of 3 earning up up to $30,000 would be covered by the Medicaid expansion. And we know the importance of health insurance coverage during this time of COVID-19. I will refer you to the Kaiser Family Foundation that spells out the many benefits of Medicaid expansion. Over 400 studies have documented the benefits. It increases access to health coverage. It increases care and services. It improves health outcomes. It makes care more affordable for families so they don't have to go bankrupt and struggle with medical debt. It's reduced uncompensated care for our hospitals by 55% in expansion states. It allows rural hospitals to stay open. It reduces state costs for state-funded health programs, and generally it grows the state economy. In terms of economic growth, the estimates in Missouri is over the first 5 years, it will increase jobs by 26,000, with many of them being in the healthcare industry, but some being in areas like construction. And it will bring $2.5 billion in economic growth. And I think with that, I'm out of time.
Yes, you have 30 seconds, but that is perfect if you're finished. Mr. Cannon, same question. Could you please discuss the benefits or detriments of expanding Medicaid?
Certainly. Thank you for having me, especially to Professor Watson for that introduction. I'd also like to put the Medicaid expansion debate in context, a bit of a broader and I think more personalized context. If I'm able to share my screen, I'll go ahead and do that. This is a 2007, not far from now in Northern Virginia, a 12-year-old boy named Diaz to dental practices. His mother couldn't find a dentist who accepts Medicaid. Medicaid pays dentists so little that very few dentists participate. A simple tooth extraction could have saved Diamante's life. Instead, an infection that began in his abscessed tooth spread to his brain and overwhelmed his system. It does not speak well of the Medicaid program that it paid $250,000 for 2 weeks of hospitalization and 2 brain surgeries that ultimately failed to save Diamante's life, but didn't pay for an $80 tooth extraction that would have both saved his life and avoided that much larger expense. A little more context about the Medicaid program. This is a saline drip. Costs about 50 cents to manufacture. Department of Justice investigators found that the Medicaid program paid $928 for this product. So not only does the Medicaid program often fail to deliver on its promise of coverage to people, it also is not a very good steward of our healthcare dollars. And if you want to know why healthcare is so expensive in the United States, the Medicaid program is one of the drivers of that, of that effect. And the Medicaid program, or the Medicaid expansion, and I would say the Medicaid program more broadly, are a distraction from real health reform. Expanding the Medicaid program in order to cover able-bodied adults, or really expanding it beyond where it is right now, is reckless. It's a distraction from real health reform. It ultimately makes the poor more vulnerable rather than less vulnerable. And it doesn't protect a right to health care. In fact, it takes away your health care rights, in particular, your right to choose how to help vulnerable patients. Now, I want to say that Professor Watson had an awful lot of information about the Medicaid program, about what a lot of studies have found about the Medicaid expansion. And I'm generally in agreement with almost all of them. There's some quibbles about some of those studies, whether we should look at those as benefits or not. For example, additional doctor's visits is not necessarily a benefit. That's an input that we're hoping will deliver some benefit. But there are studies that show that, particularly for the most vulnerable Medicaid populations, Medicaid coverage does improve health outcomes. That is an output that is important. So I'm happy to agree that the Medicaid program does improve health for some people. It spends $700 billion or so per year. If it didn't improve health, that would be a very big problem. I would also quibble with the claims that the Medicaid program is going to expand the economy in states. I think that's based really on an economic fallacy, which is the idea that if the government spends money, then that's money that would not have been spent otherwise. Actually, what happens is either the government taxes that money from someone else who can't spend it on their priorities, or they borrow it from someplace, and that money gets spent on the government's priorities rather than on someone else's. And so this sort of government spending doesn't improve the performance of the economy. It really just shifts dollars from one part of the economy to another, and often in a less productive way than if the government had just left that money where it is. But when I say to Medicaid, that means it's my time. Okay.
Sorry, I'm sorry.
I got in most of my points. There's plenty of time for the rest of them.
Yeah, we gave you extra for the opening remarks. I saw your email before, so I gave you a few extra seconds.
I don't want extra time. I only want.
We spoke about it before. So in response to that, Professor Watson, a lot of you guys have been going back and forth about the cost of Medicaid, and is it wasting taxpayer dollars? So maybe in an effort to address that, could you discuss the effects work requirements have on the overall aim of Medicaid and whether that's positive or negative?
Sure. So the question of work requirements are that the purpose of the Medicaid Act is to provide health insurance. And the purpose of having health insurance is to give you access to medical care when you need it, but also to create financial security so that when you do use medical care, you don't have exorbitant medical bills that end up causing family bankruptcies or other family crises. And Medicaid is designed both to create that access and to create that financial protection. The problem with work requirements is, one, they're built on stereotypes that the low-income adults who depend on Medicaid aren't working, and it's simply not true. 60% of low-income adults who are eligible for the Medicaid expansion are working full or part-time. Another 30% are caring for a child or a family member. They're going to school. They have an illness or injury that makes it impossible for them to work. And that leaves about 8% who include people who are recently unemployed, who are looking for work, particularly people in that 55 to 65-year-old age range who have a hard time finding employment. And these are statistics prior to the COVID pandemic. We know now that there are a lot more people who aren't employed because employment is difficult right now and dangerous for many people. My main concern with Medicaid work requirements are that we don't need them because people are working. And what they really are is a red tape requirement, a reporting requirement. They require people to report to the state on a regular basis, a monthly basis, a bi-monthly basis, where they're working, are they working, do they have a good reason not to be working? And with any reporting requirement, some of those reports get lost, people get confused. And what we know from experience in other programs is that people who should be enrolled are following the rules, end up losing their coverage. Arkansas is the only state that has actually implemented a Medicaid work requirement. And in the first 3 months in which those reports were due, 18,000 people lost their Medicaid coverage. These were people who were otherwise eligible, who were by and large hardworking Arkansas people, but didn't get the paperwork in. That is 25% of the people who were subject to that reporting requirement. So the real concern is that low-income people on Medicaid are working. We don't want to put in their way reporting requirements that keep otherwise eligible people from being able to access the health insurance coverage they need to get health care, to stay financially secure. It is particularly problematic for people who have English as a second language. It is particularly problematic for people of color, because we know in the low-wage workforce there is a great deal of employment discrimination. And for Black and Brown Americans, it is even more difficult to get into and stay in the workforce. So they get a double whammy from these reporting requirements. Thank you.
Thank you, Professor Watson. Mr. Cannon, same question if you would discuss work requirements.
Sure. So the reason why this is such a, I agree that this is kind of a marginal issue when it comes to the Medicaid program broadly and the Obamacare Medicaid expansion. The reason that it is such a big issue in so many states is that this is a very popular issue. The idea that if someone wants a subsidy from the government, they should be working and contributing taxes and meet certain criteria if they are able to work. It has a lot of resonance with voters. If you poll voters, you get strong majorities that say, yes, there should be a work requirement for able-bodied adults. And the Obamacare Medicaid expansion is all about able-bodied adults. These are childless adults who do not qualify as disabled. So by definition, if we're talking about people who are eligible for the Medicaid expansion, then we are talking about able-bodied adults. Arkansas did implement a work requirement and I can't remember if these were the numbers that Professor Watson used, but in 2018, almost 17,000 people lost Medicaid coverage for failing to comply with that work requirement. Interestingly, however, of those 17,000 people who lost coverage, all of them were eligible to re-enroll again on January 1st, but only fewer than 1,000 of them did. So 17,000 lost their coverage, and they all could have gained coverage again if they wanted to, but fewer of them did, which raises this question of, or really validates the question of, are we making sure that our scarce Medicaid dollars are going to the most vulnerable people? That's really the concern at the heart of the work requirement debate. An important facet of this debate is, we haven't touched on this yet, it's the legal aspect. The Medicaid statute says that states can use federal Medicaid dollars in order to pursue a number of objectives, and one of them is improving health. It doesn't say anything about, at least not explicitly, about states being able to condition Medicaid benefits on people either searching for work or working. And yet the Trump administration authorized the Arizona waiver, the Arkansas waiver, and said that it would consider other waivers on the grounds that work is good for individual well-being and work it can promote health, or they think it can, and so they're going to study this. If you ask me, that's a pretty thin read. I don't actually, and perhaps Professor Watson and I agree on this, but I don't actually think that the Medicaid statute authorizes work requirements. But I think that was too much of a stretch for the Trump administration to try to get it to do so. However, it does highlight that what the Medicaid program does is, even though it's take away people's right to decide not only how they're going to spend their dollars generally, but how they are going to contribute to the healthcare of people who can't afford it for themselves. You have vast majorities of Americans who agree that if you're able-bodied and you want assistance with your medical care, you should have to work. And yet the federal government is saying, no, we're not going to let you spend your resources or help the poor in the way that you would like. We're going to take your money. We're going to make that choice for you. And we are not going to require people to work in order to receive this assistance. That's one of the ways that the Medicaid program takes away your rights, and it is one of the reasons why the Medicaid expansion has been so controversial.
Thank you. Professor Watson, do you have a rebuttal?
Yeah, I'd like to rebut, and we are going to get a question about the legality, right? So I'll have a chance to talk about that. Mommy?
Yes.
I want to respond to what Michael had to say about, well, people can sign back up because I want to tell the story of one of the plaintiffs in the Arkansas case. And he was a gentleman who was working in a factory. He had a job. He'd been there for a long time. He was able to work because he had Medicaid and he had prescription drug coverage that controlled a chronic disease. He thought he got in the report he needed, and he thought he had Medicaid. But when he went to refill his prescription at his pharmacist, he found out his Medicaid had been cut off because he didn't file that report correctly. Well, without his prescription drug, his condition spiraled. He started missing work. His employer tried to actually work with him. He lost his job. He got sick. He ended up in the emergency room. He ended up having high hospital bills. He wasn't able to get back on the next day. And it's that disruption in coverage that really hurts healthcare, and why it's important we want to get people on coverage and keep them on coverage when it's possible. And again, it also points out the people who are disrupted are hard-working people who are doing their share. And that's who gets hurt by work requirements.
Mr. Cannon, did you have a response? Or the next question was about the legal implications of work requirements. Oh, you're muted. Sorry.
I don't doubt the facts of what Professor Watson says. I'm certain that it's happened more than once. However, the interpretation, I have different interpretation, which is that that anytime you want to provide charitable assistance to people, you run into what economists call the Samaritan's dilemma. If you do too much to help, it's a dilemma because we don't really like, or you have to choose between two bad outcomes. One of them is if you don't help people or don't help them enough, and then in this case, some people go without medical care, they have unmet medical needs. And the other outcome that we don't want is we help people so much that they don't care for themselves, that they don't work. We have too many people in the cart and not enough pulling it, if you will, and there's no obvious place to strike the balance. You know, there's no one obvious right balance between helping too much and helping too little. And yet the Medicaid program is premised on the idea that there is, that 36 people in Washington, D.C., or maybe a few thousand more if you include all the bureaucrats and state legislators that help to implement the Medicaid program, can strike these balances. For us.
Thank you.
And
I'm sorry, we have to move on to the next question. I'm sorry. So moving to the legal aspects, Professor Watson, why have courts enjoined work requirements in the past? And moreover, in light of these consistent rulings, what are the benefits or disadvantages of states continuing to try to implement them?
Well, I think this is an area where it sounds like Mr. Cannon and I have some agreement. The Medicaid Act does not authorize work requirements. Congress knows how to put work requirements in social legislation. It did that with the TANF program. It did that with the SNAP program, our food stamp program. It is simply not there. What has happened is that the Trump administration has invited states to apply for waivers. They're called Section 1115 demonstration waivers, which the Secretary of HHS may grant permission to do things not allowed under the Medicaid statute if they are to promote an experimental purpose that furthers the objectives of the Medicaid Act. And what we've seen litigated is whether the Secretary has acted arbitrarily and capriciously and violated the Medicaid Act in approving these waivers. And there are a couple of issues in the case. And one is, what's the purpose of the Medicaid Act? And I believe very clearly, and the courts have consistently held, it's to provide health insurance for low-income Americans, to give them access to protect them financially. And then, is it arbitrary and capricious to approve a program that's really not experimental? We know exactly what will happen, that many, many people are going to lose coverage. And what the courts have held consistently is that these waivers violate the purpose of the Medicaid Act because it is clear that many people will lose coverage. That's been ruled on in 4 cases at the district court level. We have an unanimous opinion from the DC Circuit Court of Appeals, and there is a petition for cert that is now pending before the Supreme Court, and we'll be getting a decision in that. The name of the case that's pending for the law students is Gresham versus Azar. You can Google that and you can see the Court of Appeals decision, and you can also see the petitions in opposition to cert. Why is this so popular right now? Because this is a priority of the Trump administration. Prior administrations have said it was not within their authority to allow work, that it violates the Medicaid Act. The Trump administration has encouraged states to do this, and they said very clearly that it was part of their agenda to tear apart the Affordable Care Act and to pull down the Medicaid expansion. I think that going forward, as we see a Biden administration, we are also going to see an administration with a very different attitude toward these waiver programs. And I will predict that a Biden administration will not be approving additional requests for work waivers.
Mr. Kenny?
I'd have to agree with a lot of what Professor Watson says. There was a question in the chat about how popular are these, and there are polls, including one from the Foundation for Government Accountability, that find that among all voters, 75% support Medicaid work requirements, and even a strong majority of Democrats do as well, almost 60%. So that's an interesting thing. That's an interesting data point. If 75% of voters broadly and 60% of Democrats support this work requirement, that sort of points to why we're having these debates, why Republicans are pushing this idea. They think they have a winning issue. I don't think that it is, they have the legal authorization to impose work requirements. As Professor Watson said, the statute just doesn't allow it. But, and so I actually think of work requirements as akin to sort of the Republican equivalent of the Democrats' push for the Medicaid expansion itself. It is a distraction from the fundamental problems with our healthcare sector that are making health care and health insurance so expensive that so many low-income Americans need subsidies. The aim of health reform, to my mind, should not be just taking more taxpayer dollars and throwing it at more and more people. That approach is what has driven healthcare prices and healthcare spending through the roof in the United States. Healthcare reform should be about making it so low-income people don't need subsidies. Every state of the union has a raft of regulations that it imposes on clinicians that drive up the price of medical and dental services for the poor, including the state of Maryland, where Diamante Driver lived. They forbade dental therapists from making extractions and other basic forms of dental care more affordable. If those regulations were not in place, Diamante Driver's mother, Elise, might have been able to purchase or go and afford the dental care that her son needed without having to rely on the Medicaid program to get it. Instead of having those sorts of debates about how to change the healthcare sector so that fewer people need subsidies, both Republicans, Democrats are locked in this fight over what sort of form those subsidies will take, how generous or stingy will they be, and that's why I say it's a distraction.
So our last question is kind of a few parts.
Could I
yes,
have a response on this polling of Americans? Just
yes.
20 seconds. I think it's very important to pay attention to how those questions are asked. When Americans are asked, should people work, we all say yes. What we don't have is an in-depth conversation about when you build a health insurance system around employer-sponsored health insurance, which large employers like St. Louis University can provide. What happens to people who work jobs that don't offer insurance, who work for small employers, who work day labor, who clean people's houses, who cut people's grass, who take care of our home health aides. Their incomes are changing constantly. They're often paid in cash. I'm also answering this question in the chat. No, we can't set up a way to like automatically tell who's working and what they're making all the time, because many people have complicated work lives. But I think part of what Mr. Cannon is talking about is a misconception and a stereotype that low-income people are poor because they don't work. Low-income people are poor because we have not raised our minimum wage in many years. Many of these people are working 2 jobs, 3 jobs just to break even.
I don't agree with that stereotype, and so please don't try to associate me with it.
And I didn't mean you. I meant the pollers. I will apologize.
And I would say that low-income Americans are poorer in part because of programs like Medicaid. Because programs like Medicaid do so much to tax Americans, to depress economic growth, and drive up the cost of healthcare. So that more and more Americans need subsidies, so many more than would if we didn't do so many insane things to make healthcare more expensive and access less secure. And the employer-based system is another example. All of the problems that Professor Watson describes with the employer-based system are true, and they are the fault of the United States government, the same one that runs the Medicaid program. The fact that the U.S. government has not fixed the problems that it created with the employer-based system should not be used as an argument for giving the government more power to run the healthcare sector through Medicaid or other means.
Okay. Final question. So since Missouri, we are in Missouri, since Missouri has just voted to pass to expand Medicaid, which states are similar to Missouri from a demographical or economic standpoint? And how successful have they been in terms of expansion? Additionally, how did they implement their expansion plans?
Well, 38 states and the District of Columbia have now expanded Medicaid or are about to expand. 36 of those actually are enrolling people. Missouri and Oklahoma, our enrollment will start July 1 of next year. So there are 12 states that have not yet expanded. 8 of those states are in the Deep South. About 90% of the people who could be eligible for Medicaid expansion live in one of these Deep South states, particularly Texas, Florida, Georgia, and South Carolina. In terms of Missouri, we passed a ballot initiative. We are one of 6 states to use a ballot initiative to accept Medicaid expansion. And that's an important statement about voter support for Medicaid and voter support for expansion. It does show the will of the people to expand coverage. One of the things to note about our ballot language, and I'm going to quote here from it, it prohibits the state from placing greater or additional burdens on eligibility or enrollment standards, methodologies, or practices on persons covered under the Medicaid expansion than on any other population eligible for Medicaid. That provision was on the ballot language. People saw it when they voted for it. It means that people covered by the expansion will get similar benefits to people who are covered now and are not going to be subject to additional burdens like a work requirement. I will say that in terms of states that have expanded, most, 27, have used a straight expansion as allowed under the Medicaid Act. There are 11 who are using some of these waiver programs. About 8 of those do include these work requirements, many of which have been set aside by the court. I will say that states that have expanded have seen their health insurance coverage go up. They have seen their population health improve. They have seen financial stability improve. This has not been a budget buster for state taxes or for federal taxes. In fact, the economic benefits of Medicaid, the improvements in the economy, the support for hospitals, the support for dental care, outweighs the tax money we use to support Medicaid. Mr. Cannon has talked about Medicaid as a form of charity. I think of Medicaid as an infrastructure. it is, as we use our tax dollars to build roads, we use our tax dollars to support our school systems, we use our tax dollars to support a safety net health insurance program, because no one can afford the costs if you're diagnosed with cancer, COVID-19, and hospitalized and have to go on a ventilator. There are some medical costs that are simply too high for anyone, and we share those by pooling the money. And Medicaid is a way we use our joint federal state tax dollars to support the lowest income Americans. And those include working age individuals in the expansion. It also includes our poor seniors, low income children, people with disabilities, and pregnant women, and also our people in nursing homes and home and community-based care.
Thank you.
I don't think there's much difference between the way states are implementing the Medicaid expansion, even in the waiver states. I don't think there's the difference is really worth the time discussing it. However, I do want to address a point that Professor Watson made that I think is it's demonstrably false, which is that the Medicaid expansion is popular. The Medicaid expansion is not popular, not in any state that has implemented it. And here's how we know. If the Medicaid expansion were popular, if popular means anything, it means that people think the benefits are worth the costs. There's not a single state in the union that has implemented the Medicaid expansion and agreed to take on all of the costs. 90% of the costs are coming from the federal government. So state officials don't have to raise that 90% of the cost of this program. They don't have to face the voters. And we know that that means that it's unpopular with their voters, because prior to the Medicaid expansion, no state had implemented a Medicaid expansion like this and gone to the voters and successfully said, I'll increase your taxes by this much in order to pay for this program. No state had done that. That tells us that this program is not popular. The only reason that states have passed or have implemented the Medicaid expansion is because the federal government agreed to pick up 90% of the cost. And even then, states are having a hard time convincing their voters to pay for even 10% of the cost of this program. And if you look at the Missouri ballot initiative, the most important language in that initiative was the very last sentence of the summary, which said, if passed, this measure has no direct impact on taxes. What that means is that the Missouri ballot initiative said, do you want to expand Medicaid, yes or no? It didn't say anything about how much it would cost. It didn't say this will raise your taxes by this much. It provided no information on the costs at all. It is a benefits only ballot question, which means it's an economic fantasy. And even so, it only got 53% of the vote. A bare majority of voters in Missouri approved it. So I think it's deceptive and irresponsible to claim that this program is somehow popular. If it were popular, states wouldn't need any federal dollars to get this across the finish line, and yet they need 90% of the cost to be covered. And even when they pretend to their residents that there won't be any costs, they put a ballot initiative out there that pretends that there won't be any costs to them, any increase in their state taxes or cuts to other state programs. Even then, only 53% of voters are for it. So, and I think that's actually brings to the fore a much deeper issue and a very big problem with the Medicaid program, which is sort of the corrupting influence of intergovernmental transfers, like the federal grants that finance the Medicaid program. But maybe that's a FedSoc event for a different day.
Professor Watson, any response?
Oops, am I on? I have a brief response because I think Mr. Ken is setting up a straw man here. Medicaid is a 50-year-old program that uses federal financial assistance to help states fund health care. We spent from 1935 to 1965 figuring out that financing structure. No state can fund this on their own. There are places where we need joint federal state financing, and that's what Medicaid is set up to do. Prior to that ballot initiative, we had economists at Washington University whose analysis showed that the Medicaid expansion is going to save $1 billion in the Medicaid budget by 2026. That's over 5 years. And that happens because right now the state is fully funding programs like community mental health centers, substance abuse treatment programs, that those people will now be eligible for Medicaid coverage, and we can share this cost with the federal government. Now, I think Mr. Cannon and I would disagree on whether that's appropriate. I think that is a good role for federal tax dollars to help small states be able to provide health care. I think one of the benefits of Medicaid is that it is a state-based program that can be responsive to state values. I also have to say that Arkansas had a net savings of over $400 million in the first year of its expansion. Michigan saved more than $1 billion in their mental health programs, and they generated $8 million in new state and local revenues if they could invest in other programs. We may want to talk about other ways to reform the entire healthcare system. And I know we've had candidates for office who did that, but within the structure we have now, Medicaid works. It works for state economies, it works for people. It can always be approved. And that's the terrible story of the child who couldn't get the dental care he needed. And we always have to work to improve it.
Thank you. Mr. Cannon?
Do I get a chance to rebut the rebuttal?
Yes.
Okay, so I mentioned at the outset that Medicaid ultimately makes the poor more vulnerable. It does so by increasing prices for private payers, such as prescription drugs. It increased the price for taxpayers to pay for that 50-cent saline drip all the way up to $900. It also makes the most vulnerable Medicaid enrollees, the Medicaid expansion makes the most vulnerable Medicaid enrollees more vulnerable, because the way that Obamacare sets up federal financing for those able-bodied adults in the Medicaid expansion encourages states to cut benefits for the aged, blind, disabled, pregnant women, and children before they cut benefits for able-bodied adults. Because they can save more money by cutting benefits for those more vulnerable populations than for able-bodied adults. But Professor Watson touches on what I think is the biggest way that the Medicaid program and the Medicaid expansion in particular make the poor more vulnerable. When Professor Watson talks about savings to the state because we've been able to push the cost of these state programs off onto the federal government, she makes it sound like this is free money. It's not. These sorts of discussions about, oh, we saved money for this state program and that state program are really shell games that states use to game the federal matching grants that each state receives for their Medicaid programs. But every time someone is claiming savings, what that means is the federal government is picking up spending that the state had been making itself. And this is a problem. This is a problem because the federal government, as we all know, is running deficits. It's been running deficits for a long time. The Congressional Budget Office says that all those accumulated deficits amount to a national debt that is right now about 100% of US GDP. So if we all worked all year long and didn't keep a penny for ourselves and give it all to the government, we would just pay off the national debt.
Mr. Cannon,
I
don't want to cut you off, but we only have a few minutes for, and we have a lot of student questions.
But the way that this makes the poor more vulnerable is that this cannot keep on happening. We can't keep pretending, oh, the federal government will keep picking up state costs, because eventually the federal government will run into a budget constraint. It'll run into a spending constraint. It'll shift the cost of these Medicaid programs and the Medicaid expansion off onto the states. And when that happens, and I think Professor Watson and I would agree on this, one of the first place states go when there is a budget crunch is Medicaid. Even Medicaid supporters acknowledge that states will cut Medicaid benefits, they'll cut Medicaid payments, make it harder for the poor to get care, and that makes them more vulnerable.
Mr. Cannon, thank you. Thank you. So we have a lot of student questions here. We'll start with one of the earlier ones. Could each of you share what you think the ideal way to reform our healthcare system is, and just 1 minute each, please?
Oh, I'm still unmuted, so I'll go ahead. I would do two things. Change who controls the money. We have a $4 trillion healthcare sector. More than 80% of it is controlled by people other than those whom the system is supposed to serve. It's controlled by employers, it's controlled by the government. Let the consumers control that money, and you'll see prices fall, and that's the most important thing we can do to bring healthcare within the reach of people who cannot afford it today. once you do that, it'll actually be easier to remove a lot of the barriers to competition and innovation, including cost-saving innovations that exist right now. Those are regulatory barriers.
Professor Watson?
My ideal system would make sure that everyone has access to healthcare when they need it. And we can do that. There is no ideal. There are many ways we can do that. Our present system that relies on employer-sponsored coverage is very awkward. On the other hand, asking people to move from coverage that they are used to and that they trust to a new system can be difficult. And that's been kind of the political debate we've had between the single payer, Bernie Sanders, and now President-elect Biden. We have many systems. What's most important is we need to make sure that everyone has coverage, and that means everyone. And we need to make sure that the rules are equitable. It's not equitable when Medicaid pays less than other payers, because then you get the tensions that Mr. Cannon has talked about. So I would like to see reform on that. I'd like to see reform around prescription drug pricing. I'd like to see reform that encourages doctors and other providers to provide care that's valued, that creates better value for patients and better population health.
We have another student question citing the Kaiser Foundation research showing that the UK leads the world when it comes to per capita and healthcare outcomes. What is the barrier for the US to do the same?
Do you want me to go first? So one of the questions when you look at these numbers is what kind of system do they have? Obviously, the UK has a system that is a single payer, where many of the hospitals are also owned by the government. They do not have the overhead we have. One of the things that happens in our system is because we have multiple insurance companies, we have Medicare, we have Medicaid, we have VA, there are administrative costs that get tacked on here. We also have additional costs because our doctors and our nurses actually both get paid more than they do in the UK, and we also pay a lot more for prescription drugs. So there are a number of things that explain the difference in costs between us and the UK, and you can do those cross-state comparisons with any country. I would also refer you to the Commonwealth Fund that does a very good job of unpacking some of those cost and quality differences.
I'm not sure what Charles has in mind when he says the UK leads on outcomes. There are indications that their cancer outcomes are worse than many other countries, but there are a lot of problems with making these sorts of comparisons. It's really hard to ensure that you're comparing like to like. I've never seen, looking at things like infant mortality, life expectancy, those are, even though those are outcomes, they're still not very good measures of health system performance, because those are outcomes that things other than the health system also influence, and that can vary from country to country. And I think the biggest problem that, I think the biggest problem that I've seen with these sorts of comparisons is that none of them include the category of innovation. So I'm not a fan of the US healthcare sector, but if there's one thing that the US healthcare sector does better than any others, it is come up with new drugs and medical devices, new diagnostic tests that not only end up improving and saving lives here in the United States, but those innovations disseminate around the world, and they end up improving and saving lives in other countries. And these international comparisons usually don't take account of innovation. And so if the US comes up with a new drug like Sovaldi, which is a 97% cure for hepatitis C, and then it begins saving lives in other countries, these cost and outcome comparisons that we usually see will penalize or ding the United States for all of the money that was spent developing that drug, but then credit other countries' health systems for all the lives that are saved by that drug. So whenever I hear someone compare the United States unfavorably to other countries, I say, granted, there are problems here in the United States, but what country, let me ask you this, what country that didn't develop Sovaldi should the United States imitate, and how do you make that pitch to a hepatitis C patient or someone who's lost a loved one to hepatitis C?
Thank you. So I think we're out of time. I really wish we could keep on going for a whole nother hour, but I know some people have to be in class at 1. So I just want to thank everyone for joining, and a special thanks to our speakers for coming and giving all this very helpful and useful information on both sides of Medicaid and the ongoing debate that will keep going on for a while. We'll obviously have this recording and keep the chat questions that weren't able to be answered, and maybe send them out later and keep people in touch. But again, thanks everyone. Have a good day. Have an enjoyable weekend.
Thank you, Alan.
Thank you all.
Thanks for coming, everybody.
Thank you.